in Orlando at the AHA annual meeting for On the Scene. With me is Noel Bairey Merz. Noel and I are friends, having done this a number of times before for other trials. Noel is looking at ranolazine in that really difficult group of patients, primarily women, but not necessarily, with what appears to be small vessel dysfunction, call it what you will. So, Noel, tell me about this new trial and the information, because it's important for this group.
So we conducted Rwise, a randomized controlled mechanistic 2-week short-term crossover trial. Ranolazine, of course, is a late sodium current inhibitor, and we were testing the hypothesis that the angina symptoms, often atypical in this group, are related to ischemia by testing relationships between Seattle Angina Questionnaire and then coronary flow reserve measured by cardiac MRI perfusion reserve. The trial results were negative in the entire group, meaning there was no benefit of the late sodium current inhibition for either the FACC angina or the perfusion reserve. However, we did get a positive result for our primary hypothesis, which was angina is related to perfusion reserve. We had as many improve as didn't get better, and we got a very significant and robust result. And then finally, in the subgroup with severe coronary flow reserve abnormality, we did get a positive result, and that was a pre-specified subgroup.
All right, well, that's sort of a mixed bag result, isn't it, Noel?
Yes.
So let's dissect that out a little bit. For patients that with severe abnormalities, ranolazine may be helpful. Would you agree with that?
Correct.
Okay. So what about the 55-year-old woman who comes in with these funny symptoms? I mean, you and I have taken care of a lot of them, you more than I. What's your strategy then? How would you go about dealing with this? Ranolazine, maybe ranolazine, not. How would you do it?
We've had positive trials with ACE inhibitors. Other investigators have had positive trials with beta blockade, actually works better than calcium channel blockers. Nitrates typically are not effective in this condition. The microvasculature is not sensitive to nitroglycerin. That's sort of a common practitioner oversight or mistake. So we think that these results are consistent with the guidelines. Beta blocker first. We prefer alpha beta blockers, carvedilol, that can be easily titrated in the often female patient. And then I think ranolazine is still an effective add-on agent for those with documented low coronary flow reserve.
The coronary flow reserve, just to make sure that everybody understands, is something that can be relatively easily figured out, certainly in a cath lab.
Certainly in a cath lab with an adenosine Doppler wire, so it's the same as an FFR. There's just no obstruction that you have to get across or an intermediate lesion. Easy in the cath lab, a little more challenging with Doppler flow, non-invasively with an echo. You have to be able to see the LAD and get a good Doppler signal, but people can do it. And then we have documented cardiac MRI can work, PET can also work.
So there you have it. That's a good clinical summary. Thank you, Noel. Interesting group of patients. Still no clear-cut answers, but at least a clinical strategy.
Thanks, Peter.